So today's topic will be the failing heart in diabetes. As we are all aware that diabetes is increasing day by day. India has become the diabetic capital of the world. So we'll be seeing more number of heart failure patients in diabetes. So these are some of the headings in which we will be looking in this session. So heart failure by definition, it's a clinical syndrome with signs and symptoms of structural or functional cardiac abnormality with the evidence of increased natriuretic peptides and evidence of pulmonary or systemic congestion. And there is a strong association between diabetes and heart failure. In 30% of the diabetic patients, they have heart failure. In all the RCT trials which have been conducted for heart failure, there were, in DAPA-HF, 40% of the patients were diabetic. In EMPEROR-Reduced, 45 to 50% of the patients were diabetic. But you should need to understand the staggering statistics. As the diabetes patients increases, they have a 2 to 4-fold increased risk of heart failure. Especially in young adults, it mounts into 11-fold. This has been studied in the DCCT trial, 30-year follow-up of DCCT trial and UCB trials. And now there is 22.3% of prevalence of diabetes. This is the most important one. You need to understand there is 32.7% heart failure mortality in a diabetic patient, whereas in a non-diabetic it is 3.7%. So the type 1 diabetic patients also are not spared. The prevalence is much more. The diastolic dysfunction is higher. The worse the glycemic control, the chance of heart failure is also high. So the two things, the longer the duration of diabetes and the glycemic variability and the increased HbA1c. So any 10% increase in HbA1c, 1% increase in HbA1c has a 8% increase of chance of heart failure. This is from DCCT trial, 30-year follow-up. So when you have a longer duration and the glycemic variability, especially increase HbA1c and fasting blood glucose, per se, it's a high risk factor for your heart failure. So the global incidence, it's increasing, 578 million projected in 2030. So you can imagine how much heart failure we are going to face. There are two entities, you are all aware, ischemic cardiomyopathy by means of atherosclerotic cardiovascular disease, that everyone are aware about that. I am not going to touch that. Today we'll be looking into the new entity called as diabetic cardiomyopathy. This is not a new entity, it has been in vogue. The definition was formed by all the associations since 2014. It's defined as a myocardial dysfunction without associated coronary atherosclerosis, hypertension or valvular disease. So the pathogenesis is a much complex one. It includes lipotoxicity, polyol and oxidative stress, AGE and microvascular dysfunction and autonomic dysfunction. As the insulin resistance and the increased glucotoxicity, there is impaired energy metabolism, shifting of energy metabolism from glucose to fatty acids, and there is excessive lipid deposition. And also this polyol pathway, by increasing the sorbitol, it causes fibrosis, and this AG, advanced glycation, causes endothelial dysfunction and vascular impairment. Of course, autonomic dysfunction increases the sympathetic activity, and this is the main reason for your heart rate variability and your silent myocardial infarction. So in nutshell, to say there is an increased, decreased glucose uptake, increased oxidative stress, endothelial reticulum stress, and by means of various pathways, the abnormal glucose metabolism and insulin resistance goes for cardiomyocyte apoptosis and finally myocardial fibrosis, thereby resulting in systolic and diastolic dysfunction, further resulting in end-stage heart failure. So hyperglycemia in a nutshell causes myocardial hypertrophy, fibrosis, cardiac remodeling and heart failure. So the diagnosis, it's a challenging, no specific markers, patient will be silent and the complications overlap. So you need to find it early in the disease. You need to find out when the patient, you can see from this slide, the asymptomatic individuals you need to identify, because the transition from the asymptomatic individuals, stage A is the risk factor. Diabetes per se, it's a risk factor. Apart from that, diabetes, obesity, all the stage A. And stage B, you can see the transition from stage B, immediately from stage B to C and D is very rapid with the diabetic population. So we can catch hold of these patients earlier by means of scores, risk scores. There are two scores, RX score and WASH DM score. You can have a calculation and you can catch them early so that you intervene them with the tight glycemic control as well as the newer SGLT inhibitors, which I'll be discussing in the forthcoming slides. So you need to catch them very early in order to prevent them going from a stage B to stage C and D. You should hold them as early as possible in asymptomatic diabetic patients, high risk category, as you identify them by the risk scores. There we have this newer modality of